I'm just going to shut the blinds behind me there. There's some glare.
Hi, welcome to those who've just joined us. We're just giving it a few more minutes before we get started. I'm just going to go shut a door.
Oh, I'm going to find a way to silence this. It's my parents calling. I don't know how to silence that. I'll just send them a message and let them know.
Okay. All right, well, I guess we'll get started. Hi, everyone, and welcome. My name's Fiona Lewis, and I'm glad to have you here on this webinar that's been hosted by AAMAC. AAMAC is a leading funder of research into bone marrow failure diseases in Canada, and our organization supports patient and caregivers across the country who are living with aplastic anemia, myelodysplastic syndrome, and PNH. I'm the patient support liaison for BC and Alberta, and I do invite you to keep checking our website to find out more about upcoming webinars and other services we provide. So I'm pleased to introduce our speaker for today's webinar regarding medical decision-making. Reanne Booker is an oncology and palliative care nurse practitioner in Calgary. She has worked in cancer care for over 20 years. She currently works with the palliative care consult team at Foothills Medical Center and is also working on her PhD in nursing through the University of Victoria. The focus of her research is on the integration of palliative care in oncology. Her clinical and research interests include symptom management, sexual health and cancer, the integration of palliative care in oncology, and medical cannabis in cancer care. Reanne has 2 young daughters and 2 dogs named Charlie and Dashi. So we're going to have lots of time for questions at the end of Reanne's presentation. And I invite you to type any questions you have into the chat window, which should be on the right-hand side of your screen. You can click the arrow under questions and the question box will open. And then later I'll read out the questions for Reanne to answer. So with that, I will turn it over to her to begin the webinar.
Thanks very much, Fiona. And good morning, everyone. Or I guess it depends on where you are in the country. It could be afternoon. I'm located right now in Cochrane, Alberta, so it's morning here. And yeah, thanks for joining. I know this can be a difficult topic. Certainly over the years, in my role as an oncology and palliative care specialist, this is a topic that I deal with and address frequently in my line of work, but I also address this very often personally. When family and friends have had serious illness diagnoses, they have many questions. They want to know what they should be asking their doctors and their healthcare team, just in terms of treatment and diagnosis and prognosis and all those questions that might come up. So certainly it has been something that I've got a fair amount of experience with, for sure, on a professional and personal level. So we'll jump ahead here if I can make the slides move. And I think now in the era of COVID-19 as well, medical decision making is becoming increasingly important, and we're hearing about this on the news and definitely, you know, in terms of serious decisions that need to be made about, you know, critical care and ventilator use and all kinds of difficult decisions. I think this has thrust the need for contemplation about these issues very much to the forefront for many people. And yet this is still something that many of us don't really think about or confront until faced with a serious illness or a situation where these difficult decisions often have to be made. So let's see if I can scroll ahead here. Perfect. So today I'd like to review various different considerations when making medical decisions. I'd also like to talk about advanced care planning a little bit, and then to talk about some resources that are out there to help with medical decision making. So first off, what do we mean when we talk about serious illness? Well, serious illness is the kind of illness that requires someone to be in the hospital. It could be because of something like a bad pneumonia. COVID would be a good example right now in our current situation, or a major heart attack, something like that. There can also be serious injury that would also be relevant in this context as well. And you know, this is a situation where the illness or injury might be so severe that the person might pass away, or there might be a chance that they would recover as well. And so thinking about what would be important, what would be, you know, your wishes and your hopes in those kinds of situations, those are things that often many of us don't think about, as I mentioned, until we're confronted with those scenarios. But when you're confronted with those scenarios, it's often a time of profound stress and you know, urgency in terms of making those decisions on the spot. So these are things that, you know, we really want people to be trying to think about well in advance, and not necessarily the specifics of their decisions, but maybe perhaps what their values are that might help guide those decisions in those circumstances. So historically, medicine and healthcare was quite paternalistic, meaning that the information was provided by the clinician to the patients and their families, and recommendations were made kind of in that unidirectional manner. So the doctor or healthcare team might say, this is what you should do, this is what I recommend. And now we've seen quite a shift, and I think it's a good shift, where we're moving to much more shared decision making, where it really is important to incorporate patients and family members and loved ones' values and preferences. And we need, as clinicians, to know that information about what is important to somebody in terms of their values and their preferences for how they'd wish to be treated. And that can really help inform the decision-making process, which is really meant to be more bi-directional. So the clinician and healthcare team can give information, they can even give recommendations, but it really is important and critical to have patient and family member feedback and input into making those decisions. So it's not this one way, one unidirectional manner that it used to be. It's much more dynamic and much more bi-directional, involving patients and family members as well. And I say this, and I know that in real life, you know, this may be the ideal, but in real life, I think many decisions that are made in the medical world are often still very much being made by medical providers, by healthcare providers. You know, as much as we always want to have the patient voice incorporated, I think we have a lot of work to do yet in terms of making this much better. And I've heard from people before that, this doesn't always happen where we're always necessarily incorporating patients' views and values and things like that. I think it's getting better, but it definitely could be much better. And for certain, as a patient and family member, caregiver, it is your right to be involved in this process. Recognizing again that not everybody necessarily will respond to this experience the same way, and some people want as much information as possible, and others only want what they consider to be, the absolute necessary information to know. And then there are people kind of somewhere in between. But it really is your right as a patient and caregiver to find out as much as you can and to be involved in this decision-making process. So I think off the bat, and certainly, with the internet and Google and things like that available, the patients definitely are learning a lot more about their diagnosis and various options. I think this is really important. So understanding what the condition is, and it doesn't have to be in huge great detail in terms of the biology and pathophysiology, but understanding about what the diagnosis is, I think, is really important. And asking the healthcare team questions about the diagnosis specifically. And, those early days when there is a new diagnosis can be very overwhelming, and the appointments are often already filled with so much information sharing and giving. But, it really is, again, your right to slow those conversations down and to ask questions that you may have. It's difficult to make a properly informed decision without all the pieces of the puzzle available to make that decision. I do say, use some caution when doing research online. It's best to use trusted websites. And AAMAC is a great source of information for sure. I actually sat on the AAMAC board for about 6 years. So I can say that I've got some experience in that regard, and that AAMAC is definitely a trusted source of information. It's difficult though, because there are so many sites and websites and things like that out there. It can also be overwhelming. And there can be websites that have not necessarily the most accurate information. So it's really important to use trusted websites. As Fiona mentioned, one of my areas of interest as well is sexual health and cancer. And I found over the years that if I really need to give patients specific websites to learn more information about, because typing sex into a Google search can get you some very interesting websites and not necessarily helpful websites. It can be quite interesting for sure. So using trusted websites definitely is highly recommended. So again, knowing your options. So, we talk about when there is a serious illness, we talk about disease-directed treatment. And so that's where we're intending to treat whatever the condition is. And that might be through the use of medications, depending on what the condition is. It could be surgery. In the cancer world, we often will look at things like radiation treatments and things like that. So that's kind of disease-focused or disease-directed treatment. There's also something called active surveillance or watchful waiting, where there will be lots of appointments and maybe, checking blood work here and there, and also watching to see how someone feels, and maybe holding off on active disease-directed treatment, particularly if there's not really any symptoms from the condition and the condition is kind of slowly or more indolently progressing. Sometimes we will just keep a close eye on somebody. And then also, we have options like supportive and palliative care, where the goal is not necessarily to fix or cure whatever the condition is, but the goal is to optimize quality of life and reduce symptom burden and focus on comfort. And that might still be using things like chemotherapy or different kinds of treatments that we would use still when we're pursuing disease-directed therapy. But the goal is a bit different. So understanding, what the focus of the care is and what the goal is with supportive and palliative care, which, by the way, can definitely be integrated alongside disease-directed treatment, even when we're thinking about or intending to cure the underlying condition. There may still very much be a role to integrate supportive and palliative care, and that might help along the way with symptom burden and also help with decision making and prognostic understanding and illness understanding and all those things. So it used to be that palliative care was reserved more for end-of-life care, but there's been a shift in the past few decades to recognize that if we integrate palliative care early in the disease trajectory, even from time of diagnosis, that we can improve quality of life and reduce symptoms and improve a bunch of different outcomes such as mood, anxiety, depression, for patients and caregivers alike. And so the American Society of Clinical Oncology, now a big organization in the United States, that oversees, it's a professional organization for oncologists, is now recommending that we do integrate palliative care early in the course of the disease, particularly for people who have advanced disease or for those where there is high symptom burden. So certainly with MDS and aplastic anemia, again, it depends on the severity of the condition, but there very much may be a role for integrating supportive and palliative care, even if the goal is still to cure the underlying condition. And definitely, I believe personally that there's also always a role to integrate supportive and palliative care at any point throughout that disease trajectory, just because we always want to make sure we're optimizing quality of life and making the experience as good as it possibly can be. And then definitely clinical trials might be another potential treatment option that the healthcare team might recommend. And so again, as I mentioned in the previous slide, understanding the goals of treatment I think is really important. So is the goal of treatment to slow, stop, or eliminate the disease or cure the disease? And that would be, as I said, something like, we would call that disease-directed or disease-modifying therapy. And then if there was a point in time where the person decided that disease-directed therapy was no longer a good fit, or that the benefits were being outweighed by the side effects and the adverse effects, there may be a shift in the focus of care to really focusing on managing those symptoms and side effects. And that would be, again, supportive or palliative care. But these are not exclusive. They're not mutually exclusive. You can have supportive and palliative care integrated even alongside disease modifying or disease directed therapy. So some things to think about for sure, some questions to ask. What are the different ways to treat the condition, and what are the benefits and risks of each treatment? What treatments are recommended? And so there again, that's where we're asking the healthcare provider to provide specific information here about what they think would be the best course of action, and then finding out why they think that's the best course of action. When do you need to start treatment? Will there need to be hospitalizations? And if so, how long would those hospitalizations be? That's important. There was a study many, many years ago when I first started working in oncology, and it was for prostate cancer. And it found that there was a benefit for people in terms of their survival, meaning that they lived longer when they took the treatment. And the trade-off was they had to get chemo every 3 weeks, and there were side effects associated with that treatment. The ultimate survival benefit, as it turned out, was in the order of a few months. And for somebody, that might be a worthwhile trade, that they're going to be treated every 3 weeks with chemo and they're going to feel lousy for a period of time after the treatment. But it might be worth it for those extra few months. There might be a special event coming up, a baby being born, a graduation, a wedding, something like that, or they simply might just want more time, no matter what that time looks like. But for others, they might say, you know what, if I have to be treated every 3 weeks and feel lousy, I need to get more out of it than 2 or 3 months. And so I think it's really important to figure out why the treatment option is being recommended and what the expectations are around that treatment. And again, yeah, how will we know if the treatment is working? And often that's done for aplastic anemia and MDS through blood tests and bone marrow biopsies and those kinds of things. And then again, asking the question about a clinical trial or research study, if there's a role there for the particular disease or situation. Specific questions about treatment, I think, are also really important. So where will you go for treatment? And, this is not as much an issue necessarily for people living in big cities. This becomes a bit more of a consideration when people reside in rural or remote areas and are required to travel into those larger centers for treatment. So it's not only a matter of getting a treatment every few weeks, but having to drive into Calgary or Edmonton or Vancouver and perhaps having to stay the night. There are financial and practical implications associated with that. So it's important to know, how is the treatment given? Is it pill, injection? How long will the treatment sessions take? And should somebody be coming with you to the treatments? Those are really important to know. Then side effects for sure. It's really important to know what the short and long-term side effects are. And I think in healthcare, we do a really good job about talking about the short-term side effects, and we're not always as good about talking about the long-term side effects. And sometimes it's because those long-term side effects are a little bit more difficult to predict. And sometimes it is simply that, we're able to see people while they're getting their treatment. We see them, a few weeks after their last cycle of chemo, for example, and we're in, very close communication throughout that whole process. And then when people have finished their treatment, there may be things that creep up in terms of physical side effects, psychological, emotional, spiritual effects of the diagnosis and treatment. And some of these things can be much more long lasting. And again, as Fiona mentioned, I'm quite interested in sexual health and cancer and chronic disease, and that's one that's often overlooked and doesn't always creep up until the treatment is finished. But those are things that you really want to be asking questions about if it's important to you. And finding out when you need to call for help, what's important, and definitely with aplastic anemia and MDS, we're often very concerned about fevers, particularly when people's neutrophil counts are very low, and we know that they're particularly susceptible to infections, and very often it's fever that will be the main manifestation of a serious infection brewing. So fever, temperature elevations, things like that are really important. Who do you call if you need help? Again, as I mentioned, what are the lasting side effects of treatment? How are side effects prevented or managed, I think is really important. And then the impacts on everyday life. So visitor restrictions, again, now we're seeing this in the context of COVID. This is affecting many, many people. This is something that patients with aplastic anemia and MDS have often experienced even before COVID, particularly at times of severe immunosuppression where the counts are really low. People have had to have restricted their visitation and not, be potentially exposing themselves to sources of infection. So also thinking about how this will impact ability to work or travel and those kinds of things that might be really important. And then it's also really important to ask about the interactions between treatment and other medications that you might be taking, including herbal or over-the-counter medications, vitamins, and things like that. It's really important to find out if there might be any adverse interactions between those things and the medication that's being prescribed to treat the condition. For clinical trials specifically, it's really important to find out the details. What's the purpose of the clinical trial? Sometimes in early phases of clinical trials, we're not necessarily as concerned about learning about if the drug is working specifically, but rather it might be more to find out, is this drug safe for people? And so if the goal is safety instead of what we would call effectiveness or efficacy, that's an important distinction to make. Is the expectation that this clinical trial is going to actually help with the condition, or is it just to establish safety of a product or a treatment of some kind? Will there be hospital stays? If so, how often and how long? Sometimes the follow-up for clinical trials or the assessment is very intense, and that's because, again, the trial needs to collect data on the experience, the potential side effects or adverse effects that might be happening, and all of that. So there can sometimes be more frequent visits than there would be otherwise with standard treatment. And again, finding out about travel, if that would be required, and how often there would be follow-up and checkups after the trial was finished. And then I think this last question is one that often gets overlooked as well. So how would this treatment in the trial compare with other standard treatment choices? Is this thought to be a better, superior treatment option? Or are there better options, or is it just simply unknown, and that's why the study is being done? So finding out really the intent of the study, and again, if your healthcare provider is recommending a study or a trial, to find out what they think the goal of the trial is and how that treatment would compare to standard care. And again, all the other questions apply as well in terms of side effects and those kinds of things as well. And so again, thinking about the risks and benefits of each treatment, and remembering that no disease-directed treatment is also an option. And I think that, you know, I don't ever like to hear the phrase when people say there's nothing more that can be done. I always think that there is always more that can be done. If we shift the focus from disease-directed treatment to managing symptoms and improving quality of life, that's still very much a very valuable and worthwhile goal. So I think, again, looking at the risks and benefits of each treatment and the trade-offs, and what your preferences are, both you and your loved ones, I think is really important. And considering, you know, the impact of quality of life or the impact of treatment on quality of life and independence is really important as well. And then once you've had a chance to gather all that information, you know, talking to somebody about your decision is also really important. And this is where it's important to talk through your thoughts and concerns with people that you trust. And, you know, it could be any one of these people or others. And sometimes, you know, peer support can be quite helpful. And I know that that is something that AAMAC does a great job at, is connecting people who've been diagnosed with a particular condition to somebody else who's had that condition and has been treated, so they can speak about what that experience actually looks like, what it feels like, what it's like all around. And that can be often way more helpful than talking to anybody in the healthcare team, especially when, you know, trying to make these difficult decisions. It's also completely within your right and recommended to consider a second opinion if you like, particularly when, you know, when you're faced with these very difficult decisions. So asking for a second opinion is always very valid and certainly within your right. And then again, you know, we think often about questions at time of diagnosis, but it's also important to think about what's happening when treatment is finished. So again, as I mentioned, oftentimes during treatment, we're following people quite closely. And so we're looking for side effects, we're looking for symptoms, and we're managing those quite carefully. And then there may come a point in time where treatment is finished and the follow-up schedule becomes more sporadic, or the intervals between appointments become bigger. And sometimes that doesn't always necessarily coincide with the person feeling better. And so it's really important to still maintain a sense of who should you call if things come up. What are the long-term health issues that might be anticipated or expected? What's the chance that there may be a relapse or the condition might come back? What are the concerning symptoms to kind of be monitoring? And then what do I do if those symptoms come up? How else to, you know, to maintain a healthy lifestyle, and what else should be done in terms of diet, exercise? When is it safe to go back to work? When is it safe to travel? All of these questions are really important to be asking, particularly when treatment is finished and, you know, there may not be that close follow-up as there had been during treatment. And again, support groups is one of the questions at the bottom of the list. And again, this is where I think AAMAC comes in and has been very helpful to people who have gone through treatment, and then once treatment's finished, has helped to maintain some of those connections and you know, help with some of the questions that people may have. And so again, thinking about making these difficult medical decisions, and again, as I mentioned, it's really important. So it's not always necessarily about trying to plan ahead and make definitive decisions today, but thinking about what's important to you and what your core values are around, you know, life and illness and things like that. So some examples might be, no matter the cost, I want to live as long as possible. I'll put up with anything. I'll go through anything. And other people might say, you know, no, that's not really for me. I don't want to have machines, ventilators, things like that to keep me alive. Other people will say, and you know, this is, I would say most people would like to avoid symptoms such as pain and shortness of breath. That's, I think, goes without saying that most people want to be comfortable no matter what they choose in terms of treatment. Independence is also a really big, important consideration. So sometimes the treatments that we give can really impact independence, and particularly things like bone marrow transplant. You know, we recommend that somebody have a caregiver before they pursue bone marrow transplant, because it can be such an intense, difficult experience for the patient that they definitely need a caregiver to be involved. And so if independence is really important to somebody, this may not be worthwhile of a trade-off if it's thought that perhaps the benefits of pursuing whatever the intervention or treatment might be small. It might be more important for the person to continue to live independently and just manage side effects and things like that. And thinking about, you know, what kinds of activities do you like to do and what brings you joy in life and how treatment might impact those things and for how long. Pardon me. So it's one thing if treatment is only going to make somebody feel unwell or sick for a short period of time. Many people would say, whatever, I'll get through that, I'll make the best of it, and then things might go back to normal afterwards. But if there's a thought that treatment might be long-term or indefinite, or if there's a very intense intervention like bone marrow transplant or stem cell transplant, what might be the long-term impacts of that treatment or intervention on the things that the person likes to do, the activities and things like that. So those are things to really think about. And again, I mentioned this notion of quality of life versus quantity of life. So what's the trade and what would have to be given up to get more time? And for some people, if that means that quality of life would be really poor, then it may not be a worthwhile trade just to get a little bit more time. And again, nobody has a crystal ball, so it's difficult to know how much more time somebody might get with treatment compared to without treatment. But thinking about what the trade-off might be in terms of how that quality of life might look is really important. And this can be difficult because sometimes these values will conflict or compete with each other. So, for example, if someone might say they want a natural death with very little interventions, no machines and things like that, but keep me alive at all costs. Those two kinds of sentiments or values are not quite congruent with one another. You know, so thinking about what would be important to you is really a thing that we want people to think about in advance of those crisis situations where those decisions have to be made on the spot. And so talking about that with your loved ones, talking about that with your healthcare team, you know, letting them know that, no, quantity definitely takes priority over quality for me or vice versa, I think are really critical things to talk about with your loved ones and healthcare providers. And so here's just an example of, you know, how you might consider these things. And there's all kinds of different tools that are out there that can help with making these decisions. So this one's just having the person kind of rank on a scale of 1 to 7, what's the most important. So prolonging life or maintaining quality of life. Maybe they're both kind of equally important. And then similarly, in terms of interventions, how much intervention would somebody want? So everything possible, so machines, chest compressions, different things like that. Or, you know, maybe that's not so important, and maybe it's more important to you know, have a natural death without a lot of intervention. So this brings me to advanced care planning and goals of care designation. So some of this language is, you know, more specific to Alberta. We have something called a goals of care designation. Other centers or sites in the past have used things like DNR, do not resuscitate orders, and things like that. But to make the point that advanced care planning is more a process. And it's kind of a long-term process, a dynamic process. And then the goals of care designation specifically is a medical order that helps the care team know what the person's focus of care should be. So they're a little bit different. So everybody, pardon me, should be participating in advanced care planning, not just somebody with a serious illness or condition, because again, as we've seen with COVID, there's a lot of unpredictability in life. And, you know, if someone is in a situation where those decisions have to be made urgently, it can often be very difficult for family members or loved ones to know what their loved one would want in that circumstance. And they don't want to make a bad decision. They don't want to make the wrong decision. And so they do what they think the person would want. But it can be very stressful if they don't know for sure what the person would want. And this is why it's really important to talk about these things well in advance, even when feeling healthy and well, which a lot of people think is a bit of a challenge. It's hard to reconcile talking about these serious situations, particularly if you're feeling well and there's no threats to, to wellness or life or health. But those are the best times to talk about what somebody would want. And so we really encourage people to be involved in this process early on. And honestly, as I said, it's really, advanced care planning is a gift. It's a gift for family members. It's a gift for the person, the patient, because we know that when these discussions happen, that care is more closely aligned with what they would want, and the care that we're giving is the care that they would wish to be receiving. And if we don't make these decisions and or have these discussions in advance, and we don't know what somebody would want, we definitely know that there can be treatments and things like that that can happen that are not what the patient would want. So, when health wishes are made known, we know that there's better end of life care. We know that there's less aggressive treatment at the end of life. So, less ICU admissions and less ventilation and less chemotherapy in the last few days before someone passes away. And it also takes away this lack of certainty for family members, which can really lead to better bereavement outcomes for the family member if the person was to pass away. And they've done studies on this that have found that advanced care planning has led to reduced stress, anxiety, and depression in surviving relatives when they know what the person's wishes would have been. So that's important to think about for sure. And so again, this is just an analogy or something to think about. When you go on a long car ride or trip, you're hopeful and this top driver is not prepared necessarily. They think nothing bad will happen, and maybe they have all these kinds of things that might come up. So if they're not prepared, they don't have insurance, they don't have seat belts, they don't have air conditioning, and they get going and it's a really hot trip and the road is really bumpy and maybe there's an accident. They're not prepared for those things. But you can have this other person who's still hopeful and they have a realistic attitude and they're thinking, I want to make sure I'm prepared just in case something comes up. And, so this person has all the comfort features and safety features set up and ends up having a much more pleasant trip because they were prepared in advance. And so, if we use that and compare it to the situation we're making, making decisions about healthcare and things like that. So you can definitely have this hopeful and attitude that, nothing bad is going to happen. And then you get into a situation where maybe treatment is causing bad pain or the condition or illness is causing bad symptoms and side effects and things, are not going well, but nothing's been prepared in advance. And so then we know, as I said, that there can be, less than optimal management of symptoms. There can be increased distress, poor quality of life, and there can be a lot of these different interventions and things like that at end of life that the person may not have wanted. So going to the hospital, going to the emergency room frequently, CPR, intubation, ICU, and that can lead to a bad experience for both the patient and their family members afterwards. And in contrast, if you have a scenario where you can still, again, maintain hope, but also just plan for these things that, if things for some reason, whatever it may be, may not go as planned, we want to make sure that we have these measures in place to make that experience as good as it possibly can be. And that doesn't mean that we're deviating or straying from cure as the goal necessarily. You can still very much have cure as the goal, but if we're integrating advanced care planning and again integrating supportive and palliative care along the way to help with some of those comfort measures, we've seen that does lead to better outcomes for patients and their caregivers in terms of better quality of life, better symptom management, and less distress for both patients and families if things were to go awry or not to go as planned. And this little diagram was taken from a presentation I saw. It was an oncologist and palliative care specialist who presented this a few years ago and said, we're not saying that we're getting rid of hope. And by participating in advanced care planning, it doesn't mean that you expect necessarily that things will go badly. It's just that if they do go badly, there is a plan in place. So hope is still very much part of this process. And we're not saying that, again, it's not mutually exclusive. You can still be very hopeful and still, aim for whatever the goals of treatment may be that you've set out. But also having kind of this backup plan that if things are not going quite as planned, there is a backup plan. So, some oncologists and palliative care doctors and clinicians have said, talk about and think about the worst case, the best case, and the most likely, and making sure that, you're prepared for any one of those potential scenarios. So we know that advanced care planning is not happening frequently across the country. This was, it's almost a decade old now, but I don't think the numbers have changed dramatically since 2012. And so most Canadians haven't heard of advanced care planning. And those that did, even if they discussed their healthcare treatments with a family member, they still, were not always communicating what they would want, and they're not always documenting it necessarily. They're not always sharing their wishes with a healthcare provider. And yes, as I said, more than 80% didn't have a written plan about what they would want. So that's something like a personal directive, or in Alberta we have, in addition to personal directives, something more specific called goals of care designations. And really this can be seen as a bit of a, these authors have characterized this as a medical error, because we know that if we don't have these discussions and we don't know what patients' wishes are, we sometimes get it wrong. And so if we were to intervene or act in a crisis situation, we're not always doing so in a way that would align with what the patient would want. We're doing our best, and certainly family members do their best if they're in those situations as well. But without knowing what that person would want, we find that we're erroneous, and we're delivering care that may not be what they would want. So this particular study where they looked at 16 different hospitals across the country, and they interviewed, or they looked at more than 800 patients and more than 600 family members, and they looked at patients' preferences and the orders in their charts, and 35% of patients who had orders to receive CPR when they wouldn't have wanted it, they found that there was discrepancies there, and 2% of patients who had orders for no CPR when they would have wanted it didn't get it. So I don't think I said that quite clearly, but they found that people who didn't get CPR, 35% of them actually had orders to receive CPR when they wouldn't have wanted it. And so I think that that's important. That was one of my early experiences when I was a brand new nurse. Is I had come on shift, and this was many years ago at the Cancer Center in Edmonton. I'd come on shift to look after somebody who was admitted for advanced prostate cancer symptom management. When I went to change his IV fluids in the morning, I noticed that he was not looking quite right. And shortly after, he kind of slumped over and he stopped breathing. So we called a code, and we did CPR, and we were able to revive him. And his daughter came later and said, he wouldn't have wanted that. But there was nothing documented in the chart to indicate that he wouldn't have wanted that. And if that's the scenario and there's no documentation, the default is that we will do everything because we don't want to be wrong about it if the person did want CPR. And so if there's no documentation, we tend to do everything. But in this study, as you see, 35% of patients, even though they had orders in their chart, they wouldn't have wanted it. And then 2% of patients who had orders for no CPR specifically actually did want it when they were interviewed. So this is just showing that we're not always, as healthcare providers, we're not always sure of what patients would want. We need to be asking, and we need to be documenting their wishes. So in Alberta, again, it's called, it's called across the country advanced care planning, and this is the process. This is the Alberta Health Services version of it, but the process is quite similar no matter where you live. You want to be thinking about your wishes and values, learning about your health and treatment options, choosing somebody to make decisions and speak on your behalf if you're unable to do that, communicating your wishes and values about healthcare. Really important to do this with your loved ones and also your healthcare team, and then documenting this in a personal directive. And there are personal directive templates online. Alberta's got some good ones. They're easy. You fill them out. They do need to be witnessed by somebody else, but it's quite an easy process to do. And you can be as specific as possible, or you can keep things quite vague as well. So that's a very important aspect, is making sure that's documented somewhere. And for me, when I just recently did I updated my personal directive. I wanted to add something in there about medical assistance in dying, if it should be available at that point in time where I'm in a situation where my quality of life and my recovery is not expected to be possible. If at that time the legislation permits somebody to provide medical assistance in dying or MAID, that I would want that option. And I would have my agent, the person acting on my behalf, and my personal directive. She knows very carefully and very comprehensively what my wishes would be and what I would consider to be unacceptable in terms of quality of life and meaningful recovery. And so, I've communicated that very specifically in my personal directive. The legislation right now, of course, does not allow people to include medical assistance in dying in their personal directive, but there is a challenge to the legislation being put forth, and potentially maybe amended at some point in the foreseeable future, where this may be permissible to spell this out in advance. At any rate, documenting these wishes and things like that is really important. And then, of course, I have a copy of this sent to my family physician, and my agent, the person who's supposed to act on my behalf, has a copy as well. So if something should happen and I can't speak for myself, I know I have peace of mind that that documentation is there, and somebody will be able to make decisions aligned with what I want. And this is a process. So of course, it doesn't mean that just because I decided that today that I wouldn't want life-sustaining measures or, life prolonging measures, that maybe things change in a few years or a few months, or something with my health has changed. And this is a dynamic process. And certainly just because you make a decision today doesn't mean that decision is written in stone. So again, really the order, and this terminology changes from province to province. We in Alberta use goals of care designation orders. That's the tip of the iceberg. The goals of care conversations, the advanced care planning piece, that's kind of what's below the surface. And that's the really important part to be involved in on an ongoing basis with family and loved ones and your healthcare team. So again, in Alberta, this is the language we use. We have care, 3 types of care, I guess. So medical care is the kind of care where, we're looking for things to fix and fixing them. Resuscitative care is, full resuscitation if something should go wrong, if somebody's heart should stop, or something serious should happen. This type of care is, utilizing those interventions that might be used to sustain and prolong life. That might include intensive care. That might include CPR and chest compressions. And comfort focus of care, I think it doesn't mean that if you choose these other levels that you don't have comfort. Comfort is always part of these other types of care. But a comfort focus would be, we're no longer really looking for things to fix, but we're doing everything we can to optimize symptom management and quality of life. And now that might mean that if somebody has pneumonia or a cough, if they were getting medical care, we might actually do chest x-rays and send samples of the stuff they're coughing up to figure out what exactly is causing the cough and the shortness of breath. And then we would treat with antibiotics or whatever the appropriate treatment would be in that situation. With a comfort focus of care, if there's a cough, we might not necessarily do all those tests and things, but we still might use an antibiotic because we might feel that using that antibiotic will probably help alleviate some of those symptoms, and therefore it's aligned with the comfort focus of care. But we might not be doing all those other tests and intrusive or invasive procedures that can become quite burdensome, particularly when disease is very advanced and towards end of life. So this is the form we use in Alberta, and again, it's intended to be updated frequently. These discussions should be happening frequently. And then the person is supposed to carry one of these goals of care designation orders. Are supposed to be on their fridge or somewhere visible. So if there is an urgent situation and the ambulance is called, the paramedics and emergency medical services personnel know what the person's wishes would be and can act accordingly. So just an example of thinking about some of these things. So CPR, a lot of people say, definitely if my heart was to stop, I would want CPR, no questions. It needs to be part of my care. But if we look more carefully at CPR, and if people have a serious discussion, a comprehensive discussion about CPR, it's important to realize that, you know, in the general population, and we're speaking here of healthy people, if we did CPR on 100 people, only 18 of those would survive and leave the hospital. If there's a serious illness like cancer or heart disease or kidney disease, only 10 of those would survive CPR. And then people who have a critical illness and are in the intensive care, only 2 of those would survive CPR. And then again, in the overall population, if somebody is older than 75, only 15 of those would survive CPR. And I think not many people know those numbers. They think that CPR will be successful and that's why they want it. And also thinking about this, so of those survivors, those numbers I just told you, about a quarter of them will go home independently. So that's where everybody would want to be probably after CPR. About a quarter of them will go home, but will require help, and that might be indefinite. And about half of them would need to live in an institution like a nursing home or a rehab center. Half of them would have problems like memory loss, problems with attention, and problems getting things done. So again, what is the trade-off in terms of benefits and potential risks? And these are the different things to think about with CPR. So number one, you want to know what's involved. What are the possible advantages? Well, it actually might prevent immediate death, and the person might return to near previous function. Then there's a bunch of different disadvantages that might happen. There could be a stroke or a brain injury because of lack of oxygen. There can be broken bones because of the CPR and the chest compressions. Maybe, I mean, it's not going to help the underlying health issue. So if it's cancer that led to the heart stopping, or a heart condition that led to the heart stopping, CPR won't fix that health issue. And so looking at, you know, all these benefits and risks associated with the different options, so CPR and no CPR, and you can see how they've broken down the, you know, what it is, first of all, is the intervention and what the advantages and disadvantages may be. And again, I showed this already. This is just a table kind of summarizing, you know, the potential adverse outcomes after CPR. And again, it really depends on the person and their specific situation, how old they are, the other medical conditions they may have. But that's just an example of thinking through a difficult medical decision that might have to be made at some point in someone's life and kind of weighing the risks and benefits. And so shared decision making, again, is really important. That, you know, I think it's important to emphasize that, you know, it's not always all treatment options that are necessarily going to be on the table, because some of those might actually be thought to bring more harm to somebody than good. And so, you know, this decision making process really involves definitely your preferences with some input from the medical care team as well to reach those decisions. As I mentioned, there are lots of different resources out there. Plan Well is a Canadian organization, and they've got a great booklet for patients as well as for substitute decision makers. My ICU guide, I think, is also really interesting and helpful. It talks a lot about the concerns and potential issues with ICU treatment and what that experience might look like. There's also this guide that helps to distinguish the legal terms that are used in each province. Speak Up Canada is a website all about advanced care planning in Canada. It's also got a lot of great resources. Alberta Health Services here in Alberta has a website all about advanced care planning conversations with some good resources and booklets and workbook or little work guides to work through with your loved ones to help think about different decisions and things like that that might have to be made. Again, this is the Speak Up Canada website, which has got a lot of different resources available. And then there's different decision-making tools as well, and this one's from Ottawa. But you know, you can put down the different potential decisions that you need to make, and then the reasons, the benefits and risks and things, just like I showed you with the CPR. And then, this can really help you to come to a decision, and this can also help your care team and your loved ones to know why you've made a particular decision. And then knowing their values, if you're the substitute decision maker, knowing somebody's values and reasons why they want or do not want a particular treatment can be very helpful, particularly in times of crisis when those decisions have to be made immediately, and it can be a very stressful time for everyone involved. And so those are all my slides and all the things I wanted to share. And I'll just end with this. It's always about maintaining, and I would even say optimizing hope. This is something that my 9-year-old daughter did when the lockdowns for COVID and quarantine all began a few months ago. She has a little collection of shells, and she decided to make this little diagram or picture of hope, and always wants people to maintain hope at all times. So I'll stop talking now and turn it back over to Fiona, and we can see if there are any questions at all. And again, I thank you all for your attention and for tuning in this morning.
Thanks, Reanne. I'm just unmuting the lines. If anybody would like to just ask a question, you're free to do that. Give it a minute. Or you can, as I said, type one in the chat.
And you can also email me directly as well if you like. Happy to answer questions by email. And this is a topic that can be difficult to do virtually. It's nice to do this face to face and have a little bit more interaction and conversation around these difficult topics. But we have to do the best we can in the era of COVID.
Maybe I'll just ask you a question, Reanne. I know for some patients, if they decide to refuse treatment, it can be, either difficult to tell family members that, or friends and family have difficulty accepting that decision. Do you have any advice on how to negotiate those conversations?
Yeah, and that's, we see that very often, and particularly we see it with younger patients, but we see it across the spectrum for sure. And that can be very difficult, and sometimes patients will be fearful or apprehensive about saying that they don't want treatment because they don't want to let their family members down, they don't want to let their care team down, and so they push through and pursue more treatment even though that's not what they want. Or as you say, if they are to let their family members know, it's not working anymore, the side effects are getting to be too much, I want to focus on comfort, and then they may have a family member or loved one push back and say, no, you have to keep fighting, you have to keep pursuing treatment. This is where we often will convene a family meeting, and so we'll have the person's doctor, and very often we'll involve somebody from palliative care, possibly somebody from psychosocial, so a psychologist or social worker or a spiritual care provider, and we have a discussion all together. And that it can be very supportive for the patient, so they don't feel like they're on their own trying to share this information with their family members, when they've got the support of the whole team behind them to say, look, we can tell you that treatment right now is doing more harm than good. And sometimes the family members need to kind of hear that from the whole team rather than just the patient. And so it can be a way to kind of remove some of the burden or the pressure from the patient to share that information. And we've done that with people, face to face, certainly in hospital or in people's homes. We've, had people brought in via Zoom or telehealth if they're residing outside of Alberta or can't make it to be there for those kinds of discussions. But I think that that's certainly a way that can really help, relieve some of that pressure and burden on the patient. And we see that family members, when they hear that information being presented in a more kind of objective way from the team, it resonates with them, and they very often then are okay with the decision, as difficult as it might be. And then it also allows us as a team to say, well, hey, we know this is hard, and we're going to support you as a family through this, and we're going to support the loved ones who are struggling with the decision as well. So it really is that comprehensive support and care for the patient and their loved ones.
Great, thank you for that. Just seeing if there's any other questions. Well, seeing none, I'll just let everybody know that we're going to post both the a recording of the webinar as well as Reanne's slides on our website. So you'll be able to go into the slides and look at some of those resources that were at the end of the presentation. So with that, I just want to say thank you very much, Reanne, for your time today and for sharing all that. You certainly make a good case for us all to be thinking and talking about advanced care planning. So I appreciate you bringing forward the discussion. And just to let everybody know, we're going to be slowing down with the webinars over the summer, but we plan to offer more in the fall. One idea that Reanne had was that she could do one for us on medical cannabis. So I'd love to hear if any of you are interested about that. In hearing about that, you can email us at AAMAC, or just with any suggestions you have for webinars, please let us know. So yeah, I think we'll end it there. Thanks again, Reanne, and have a good rest of the day.
You as well. Thanks so much, everyone, and have a great day. Thanks.
Okay, bye-bye.
Bye.